What if COVID-19 death counts were influenced not by medicine, but by money? Welcome to a journey where we will unravel a story that has been buried under layers of complexity and confusion. A story that intertwines public health with financial incentives, a narrative that raises questions about the very heart of the pandemic we've been living through. We begin this exploration with a provocative premise. What if the numbers we've come to know, the COVID-19 death counts, were not just a reflection of medical reality, but also influenced by monetary rewards? It's a bold assertion, one that certainly requires a deep dive into the facts and figures. Imagine a scenario where doctors and hospitals could potentially be financially incentivized to report deaths as COVID-related. Sounds far-fetched, doesn't it? But what if evidence points towards such a possibility? What if the lines between medicine and money began to blur during the height of the pandemic? To understand what happened, we have to follow the money. We have to trace the flow of funds and understand how the system of financial rewards and reimbursements may have affected diagnostic decisions. We need to delve into the workings of the CARES Act and uncover the truth about Medicare COVID-19 reimbursement bonuses. Were there really bonuses of $13,000 for each COVID-19 diagnosis and up to $39,000 for ventilator use? And if so, when billions were at stake, can we really say incentives don't matter? We need to hear from those on the inside, the doctors, the whistleblowers, who claim there was pressure to list COVID as the cause of death. We need to understand the controversy, the allegations of distortion versus the health agencies denying any wrongdoing. And finally, we must scrutinize the death certificates. Were they fact or fudge? How did the CDC's flexible guidance on attributing deaths to COVID, even without a confirmed test, affect the numbers? Now let's delve into the payouts. As we embark on this journey of discovery, let's remember to keep an open mind, to question everything, and to follow the money. As part of the CARES Act, hospitals received financial benefits for COVID-19 diagnoses and treatments. But let's break this down a bit more. What exactly does this mean? It means that for every patient diagnosed with COVID-19, the hospital received $13,000. And for each patient that required a ventilator, the payout jumped to a staggering $39,000. Imagine the kind of financial boost that would provide to any hospital, particularly during a pandemic. Now, what was the rationale behind this seemingly exorbitant payout? The idea was to incentivize hospitals to prioritize COVID-19 patients and ensure that they had the resources they needed to combat this novel virus. It was a well-intentioned approach, designed to help hospitals manage the surge in patient numbers and the increased strain on their resources. But here's where it gets a bit murky. With such significant financial rewards in play, it's reasonable to question whether this might have influenced the reporting of COVID-19 cases. In other words, did the promise of increased funding inadvertently encourage hospitals to overdiagnose or even misdiagnose patients with COVID-19? It's a tricky question. On one hand, it's hard to imagine that healthcare professionals would compromise their integrity for financial gain. These are individuals who have dedicated their lives to helping others, after all. But on the other hand, we can't ignore the fact that hospitals, like any other businesses, have financial obligations. They need funds to pay their staff, maintain their facilities, and provide quality care to their patients. The point here is not to cast blame or point fingers, but rather to highlight the potential for bias and conflict of interest that can arise when financial incentives are tied to medical diagnoses. It's a complex issue, and one that warrants further investigation. So, when billions are at stake, can we really say incentives don't matter? That's a question each of us must grapple with as we continue to navigate the fallout of this global pandemic. Some insiders voiced their concerns about the system. One such voice was Dr. Scott Jensen, a family physician and Minnesota state senator. Dr. Jensen voiced his concerns about the financial incentives involved in reporting COVID-19 cases and deaths. He pointed out that Medicare was offering hospitals $13,000 for each COVID-19 diagnosis and a whopping $39,000 for each patient requiring a ventilator. Dr. Jensen wasn't the only one to raise the alarm. Other whistleblowers, many of whom wished to remain anonymous for fear of professional repercussions, echoed his claims. They reported feeling pressure to list COVID-19 as the cause of death, even in cases where it may not have been the primary cause. But why would they feel this pressure? It all comes back to the money trail. With billions of dollars in federal aid at stake, Could it be that some hospitals were tempted to inflate their numbers? This question sparked heated controversy. On one side were the doctors and whistleblowers alleging distortion. On the other side were health agencies and fact-checkers denying any wrongdoing. They argued that the financial incentives were simply a necessary measure to support hospitals in a time of unprecedented crisis. The debate raged on, with both sides presenting compelling arguments. Yet, the controversy itself is revealing. It shows that in a time of crisis, even the process of recording deaths can become a battleground for larger issues. Issues of trust, transparency, and the potential for financial incentives to influence medical decisions. In the end, it's not about pointing fingers or assigning blame. It's about understanding the complexities and potential pitfalls of our healthcare system. It's about asking tough questions and demanding transparency and accountability. And it's about listening to those voices from inside, the ones brave enough to speak out, even when it's unpopular, even when it's uncomfortable. The CDC's guidance on attributing deaths to COVID was, to say the least, flexible. Imagine a line. On one end, someone has died with COVID. On the other end, someone has died from COVID. Now, can you pinpoint exactly where the line blurs? That's the challenge we faced during the height of the pandemic. The Centers for Disease Control and Prevention, or CDC, provided guidance to medical professionals for attributing deaths to COVID. Their recommendation was flexible, to put it mildly. Even without a confirmed COVID-19 test, the cause of death could still be listed as COVID-related. Now let's take a moment to understand this. If someone came into the hospital with a heart condition, and they happened to test positive for COVID, their death could be listed as COVID-related, even if the virus did not directly cause their demise. This is what we mean when we say dying with COVID, rather than dying from it. This raises a crucial question. How many of the reported COVID fatalities were truly caused by the virus, and how many were simply cases where the deceased had tested positive for it? It's a question that's been asked by many, yet the answer remains elusive. And it's not just a matter of semantics. The distinction between dying with COVID and dying from COVID has significant implications, not only for our understanding of the pandemic's true impact, but also for the allocation of funding. Remember, COVID diagnoses were financially rewarded. The more COVID deaths a hospital reported, the more funding it received. And with the CDC's flexible guidance, the line between dying with and dying from COVID became even blurrier. This in turn raises significant ethical concerns about data inflation. Were hospitals incentivized to over-report COVID deaths to secure more funding? Were our COVID death counts distorted by financial motivations rather than medical realities? We may never know the full extent of this issue. However, it's clear that the question of how we count COVID deaths is far more complex and potentially far more controversial than it first appears. This raises significant ethical concerns about data inflation, especially when funding is tied to those numbers. What happens when public health meets profit? Let's pause to ponder this provocative question. It's a conundrum that pushes us to unravel the intricate threads of trust we've woven around our healthcare system. Trust is the bedrock of any system, especially one that holds our lives in its hands. So when that trust is shaken, the tremors reverberate through the very foundations of our society. The COVID-19 pandemic and the questions it raised about death certification have certainly jolted our faith. Now it's important to acknowledge the counterpoints. Fact-checkers have been quick to counter the claims of financial incentives influencing COVID-19 death counts. They argue that the complexities of medical billing and the dire circumstances of the pandemic necessitated the financial support provided to hospitals. They assert that the intent was not to skew death certificates, but to ensure hospitals could continue to provide care amidst a raging global crisis. However, we must not let these counterpoints blur the bigger picture. The narrative isn't just about the specifics of the CARES Act or the intricacies of Medicare reimbursement. It's about the perception that was created, the doubt that was sown, and the trust that was eroded. When the public starts to question whether profit might be driving pandemic response, the damage goes beyond a single health crisis. It undermines faith in public health institutions. It breeds suspicion and cynicism, creating fertile ground for misinformation and conspiracy theories. And once trust is broken, it's a Herculean task to rebuild. So we circle back to our opening question. What happens when public health meets profit? The answer isn't simple. It's a tangled mix of necessity, survival, and ethics. It's a dialogue we must continue to have, openly and honestly. As we conclude this exploration, we leave you with another question to ponder. We were told to trust the science, but what happens when science is funded by politics?